Hi, good evening friends. Pradeep Pendyala, your buddy, and today I am going to talk about something very interesting, that is about Bier's block of anesthesia. It's nothing but intravenous regional anesthesia, IVRA. It's an anesthetic technique on the body's extremities where a local anesthetic is injected intravenously and isolated from circulation in a target area. The technique usually involves exsanguination of the target region, which forces blood out of the extremity, followed by the application of tourniquets to safely stop blood flow for a limited period of time. The anesthetic agent is intravenously introduced into the limb and allowed to diffuse into the surrounding tissues, while tourniquet retain the agent within the desired area. I hope you are understanding. Even if you have not, I'll make it very simple to understand. Let me tell you, this use of tourniquet and injected anesthesia was introduced way back in 1908 by August Bier. He used an smart bandage to exsanguinate the arm and injected cocaine between two tourniquets to rapidly induce anesthetic and analgesic effects in the site. Today, after nearly 110 to 120 years, still the technique is very useful. Why? Because it's very economical. Rapid recovery would be there, and reliability and simplicity. Absolutely simple, absolutely reliable, a rapid recovery, and due to its economy. Wow. Now let's talk about how it is normally done. Protocols vary depending on local standard procedure and the extremity being operated on. A vast majority of practitioners begin by exsanguinating the limb, as Bier did way back in 1908 with an elastic bandage, which is known as a smart bandage, squeezing the blood proximally towards the heart. Then the pneumatic tourniquet are applied to the limb and inflated around 30 to 50 millimeter mercury above arterial pressure to occlude all blood vessels, and then the elastic bandage is removed. Let me tell you, a high degree of local anesthetic, typically lidocaine, a high dose of local anesthetics, typically lidocaine or pilocaine, without adrenaline, is normally injected. Without adrenaline, either lidocaine or pilocaine, never bupivacaine. Okay? Bupivacaine should never be used. A high dose of local anesthetics, typically lidocaine or pilocaine, without adrenaline, slowly injected as distally as possible into the exsanguinated limb. The veins are filled with the anesthetic with the setting. When the anesthetic starts setting into the local tissue after approximately 6 to 8 minutes, after which the surgery or reduction or manipulation of the region may occur. It is important that the region is isolated from active blood flow at this time. Analgesic effect typically remains for up to 2 hours depending on the dosage and type of anesthetic agent being used. The wait time and isolation of the blood flow from the region is important for avoiding an overdose of the anesthetic agent in the blood. which can lead to hypertension, convulsion, arrhythmia, or even death because of local anesthetic toxicity. Let me repeat it. The cardiotoxic local anesthetics like bupivacaine and atidocane are strictly contraindicated. Never try bupivacaine in this Bier's block. The safety and effectiveness of Bier's block is well established in clinical literature. However, cardiotoxic local anesthetic agents like bupivacaine and atidocane are contraindicated, as I have just mentioned. Shorter procedures like up to 2 hours are preferred when Bier's block is applied on the distal limb, especially on the forearm, except when the patient is contraindicated for tourniquet use, such as in sickle cell anemia, where there is a risk of massive hemolysis due to low oxygen tension, or hemolytic crisis due to restricted blood flow. A systematic review of IVRA related complication found few cases reported with morbidity. But I'm sure the modern practice now includes various safeguards to improve patient safety. Anesthesiologists and surgeons cite proper selection, inspection, and maintenance of equipment as important safety measure to avoid complications. The safest tourniquet equipment should have IVRA specific features such as independent limb occlusion pressure, measurements for each channel as well as dual bladder tourniquet cuffs combined with dedicated safety lockouts that reduce human error. I'm sure you know normally 2 cuffs are usually selected, proximal and distal, which are separately inflated. So that is known as dual bladder tourniquet cuffs. Additionally, IVRA protocols should include procedures for regular preventative maintenance of the equipment and performance testing, whether manual or automated, prior to the surgery. Otherwise, catastrophic results can occur. I'm talking about adjuvants. Talking about adjuvants like benzodiazepines and fentanyl also have been used occasionally by various anesthesiologists to prevent seizures and improve nerve blockage. Now, improved protocols, including adherence to standardized practice, may also help ameliorate the chance and the effect of complication. For example, limb protection padding and a snug tourniquet application prevents tissue damage. While sufficient but not excessive tourniquet pressure ensures that anesthetic remain within the limb without risking injury. That reminds me, if the tourniquet has been inflated to a pressure of 250 millimeter mercury for the upper limb, the maximum time permitted is around 120 minutes. That means 2 hours. And similarly, the same time, if the pressure has been put to a maximum pressure of 350 millimeter mercury for the lower limb, the upper limit is around 2 hours. After that, if you still want to continue, the surgery is not over and you want to further maintain this tourniquet, you have to deflate it for 5 minutes, at least for 5 minutes, and the surgery can continue after that. So that is very essential. You cannot keep it for a very, very long time. That's very unsafe. After 120 minutes. Care should be taken to avoid premature release or lack of inflation in the cuff. That would be very dangerous. Premature release, that means once this Bier block has been placed, minimum 30 to 45 minutes. Only after that, it can be deflated, not before that. Otherwise, there will be local anesthetic toxicities. Should complications occur, constant physiological monitoring and ready access to resuscitative drugs and equipments should be readily available. Otherwise, you don't ever undertake. Hope it was interesting. I'll be coming back again with something equally interesting. Until then, goodbye. Take care. This is Colonel Pradeep Pendyala, Professor of Anesthesiology, signing off for tonight. Bye-bye.